Thank you.
Hi all, good evening. It's great to see folks trickling in. We're going to give about 1 more minute for more attendees and the rest of our working group representatives to join. So thank you for your patience, and we'll get started in just about a minute.
Hello, good afternoon.
Good afternoon. Welcome. It feels like evening with it being so dark, but I think we may have even more light than we did in December. So I'm hopeful. We're heading in the right direction. Awesome.
That's true.
All right. See our numbers growing. So with that, we are going to go ahead and get started. I'm excited to dive in today. We have a full agenda. But before we do, let me introduce myself. So good afternoon, everyone. My name is Ann Jensen. I'm the Innovation Officer here at Nevada Medicaid. I'm leading our children's behavioral health transformation work along with an army of folks, both within Medicaid and our sister agencies. So really thankful and excited to be here to share some updates with you all today. So with that, I'll call this meeting to order. I do want to note that our agenda, we have an addition under our follow-ups from the December working group, which is that our Department of Justice settlement has been signed. And so we're going to spend a good amount of time today walking through that. I want to share a little bit more about this document and what that means for our transformation work more generally. So with that, we're going to go ahead and move through our working group representative roll call. So from the top, Matt, are you here? Matt, we'll come back to you. Leah. Lanisha. And JD? Okay, I know a number of folks, Devin and Annalicia both, and I believe a couple of our parent representatives are at a youth mental health summit in Clark County today. So we do expect a little bit of a smaller group from our youth and family side, but for those that we may have missed, we were excited to have you. So we'll come back and please let us know when you join. But with that, Luke, are you here?
I'm here.
Wonderful, thanks, Luke. All right, we'll move to our provider representatives. Alana? Okay. Dave?
Present.
Welcome, Dave. Dr. McGrew?
I'm here.
Wonderful, thank you. How about Dr. Freeman?
I'm here.
Thanks, Dr. Freeman. Dr. Cooper?
I'm here.
Good to see you, Dr. Cooper. Glenda?
I'm here.
Wonderful, thanks, Glenda. Natalie? Okay, we'll come back to Natalie. How about Stephanie? And Janelle?
I'm here.
Welcome, Janelle. And Angie? I think Angie will be joining us in a couple minutes. Nikki? How about Gwyneth?
Present.
Thanks, Gwyneth. How about Jessica?
I am here.
Thanks, Jessica. Miambi?
I am here.
Welcome. And Shayla?
I am present.
Welcome, Shayla. And our community partner representatives, Bree?
I'm here.
Welcome, Bree. And
Thank you.
Karen?
I am here. Happy New Year, everyone.
Happy New Year. Thank you, Karen. And Robin? How about Jonathan? I believe Jonathan will be joining us shortly. And Santosha?
Here.
Welcome, Santosha. Are there any representatives that have not yet gotten a chance to introduce themselves that perhaps were earlier in the list? Okay. We have met quorum, so we're going to go ahead and move forward. But if you join at any point, as folks join, and I'll keep an eye on the list, we'll make sure folks get a chance to introduce themselves, and we will note that for the record as well. So with that, I'm excited to turn over to Stacie Weeks, our administrator, for a few updates on the settlement agreement.
Hi, everyone. Happy New Year. I just want to say thank you guys because I know everyone's super busy and taking an hour or two out of your week. It's sometimes hard. So I just want to say thank you all for showing up and being on these calls with us. We're really excited. Next slide, please, to announce, I think most of you probably saw in the news that the settlement agreement has been signed by the U.S. Department of Justice and our governor's office. It's a huge win. Very excited to finally have that part of the conversation behind us. And now we can really move forward and talk about what's in it and then what we're doing. And then also think about what else we need to do to meet the purpose and goals of the agreement. So on January 2nd is when it was signed. That's the date that it's effective under the agreement. And obviously there is a link, and hopefully, Anne, you can maybe put it in the chat for folks if they want to open it up. It is a lengthy document. It makes really fun reading over the weekend. So if folks feel up to it, I will tell you, I've read it many times. So, but it's always learned something new. It's a very meaty document, but we're very pleased to have this done. Next slide, please. So just real quick, I wanted to walk through, there are these different sections of the agreement. We had a different plan for today's meeting until the agreement got signed, and we decided we really want to get you guys really up to date on what's in here and all the sections, what's required, what are the standards, what's the goal, and who it's applying to. And then think about what the work that we're doing and how it relates to that, and then where we can really engage you all in this work. But really, there are 13 big sections that outline all the requirements for our state to achieve compliance. And the compliance issue is under the Americans with Disability Act. Section 2 includes a lot of definitions, such as behavioral health services and other important things. I think that throughout you'll want to go back and reference if you do read the document. Section 7 outlines stakeholder requirements, including things that involve this work group. So I think that's something we want to raise up, probably in more detail at the next meeting. And then just a note that highlight that the compliance will be audited and really evaluated by an individual who we refer to in the agreement as independent evaluator or reviewer. This will be someone we will contract with and pay, who will report back to the Department of Justice about our work. But also we hope that we'll engage some with this work group and be a participant in some ways with you all, but also an advisor to us. We're very excited about that because it's always helpful to have expert advisors who have worked on these types of things in other states, and the individuals that we'll be bringing in with the contract that was listed in the agreement, we believe are national experts in this. So we're excited about that. And just to note that the hospital provider tax funding, like it's funding a lot of this work, is also going to be used to fund that contract. The 5-year term, it's a 5-year term. So we have 5 years. And as you guys know, 5 years feels like a long time, especially when we have needs right now, right? I know probably many of you on this call know of a child who is not getting services right now. But we have 5 years, and I still feel like that's not long enough sometimes when it comes to healthcare. But we are going to do everything we can to get this agreement done. Maybe before 5 years would be our ultimate reality and goal. But we do have a 5-year term. Next slide, please. So the purpose, so there's at the very beginning, it really outlines the purpose. And I wanted to just kind of ground us in that today because it's something we always have to come back to and really thinking through the project. So the purpose of the agreement is to prevent children from being removed from their family home to obtain treatment for behavioral health conditions. And really this, we're talking about preventing children from unnecessarily entering hospitals, inpatient settings, residential treatment facilities due to unmet behavioral health needs in the community, right? So it's really trying to prevent what we often see happen a lot in Nevada, which is placement in what we call a psychiatric residential treatment facility or a residential treatment center. So it's really trying to move away from that by building out a community-based service model to support children, families, and foster care families in a way that helps children stay in their home. The third piece is really supporting those who are in a residential facility, because there are some kids that maybe need that more intensive services and that there is no other option, right? We can't prevent every child because some children may have that level of need. But when they do go into a residential setting, how do we help transition them back to their community, right? In a successful way, and making sure that the services they receive in the facility and in the community are appropriate. So all of these things, it's a big task, but it is exactly what we need to be doing, right? The other piece here is the goals that are part of that. So really developing, like I mentioned, that community-based service system that will be funded through Medicaid reimbursement. And we'll talk, it's come up a couple times, like what about private families who are on private coverage? We do have a Katie Beckett option. It's an option for children with disabilities, but with behavioral health, when they're intensive needs, we can include children with certain behavioral health conditions. So we're looking at ways to allow families who are higher income, for example, that have no option in the private market, perhaps being able to pay a smaller premium to access some of these services. So I want to just note that even though it's not part of the agreement, we are looking at some of that work as well as how to help more children. But we are focusing right now for sure on this focus population, which is Medicaid eligible children. And then also this third goal here is to ensure services are sufficient, meaning they prevent unnecessary institutionalization and ensure children with behavioral health needs have the supports they need at home. And also when they become adults, that they can live independently, right? We want children who have behavioral health challenges to be able to transition as youth and then as young adults and then to adults and have jobs and have employment and thrive. So we'll talk about it a little bit, but children is a specific definition. For those of you that may not know, the ADA is really from a state perspective and under the agreement and Olmstead case, which is where this agreement is really founded on, comes from the fact that we are liable as a state and we have a duty as a state to ensure that children with disabilities, which includes children with behavioral health challenges, that they have access to state-funded services that ensure community-based living. So we don't, right now, our service model, which is very state-funded and Medicaid, is really driving an institutional model. And the goal here is to move away from that. So that is what we're here to do today and in the next 5 years with all of you at the table. Next slide, please. I'm going to turn it over to Anne because she knows this better than I do and all the details and can walk us through high level what the focus population is and then walk us through each of the agreement sections and kind of our plans going forward. But at any time, if you guys have a question or, if you want to put in the chat, we can take breaks here and there and we can kind of answer as we go too, because I don't want folks to feel exhausted by the end. So feel free to drop a question in the chat and we can take a break and answer some. Go ahead, Anne. Sorry.
Absolutely. No, thank you, Stacie. This is a long legal document. So what you'll see in a couple of these slides is the blue box is the settlement language that we've copied straight from that document I dropped in the chat. And on the left, we're trying to translate that into language that resonates a little bit more with how we understand the work. So to Stacie's point, if you have questions at any time, please do drop those in the chat. I think there's a couple key questions that we want to answer. The first is, what population is the settlement agreement focused on? And so for the purposes of the settlement agreement, the definition is called the quote unquote focus population. And so you'll see in that blue box exactly what that entails. But at the highest level, what that means is this is focused on Medicaid eligible youth, which we know is about 1 in 2 youth here in Nevada. Eligibility for the program is based on their need for high acuity behavioral health services. So to Stacie's earlier point, these are youth that either are in or need hospital or residential treatment facility care, but could benefit from a more robust array of services that may prevent them from going to that setting. And so all settlement terms, everything in that whole document applies to this specific population with 2 exceptions. One is the work we'll do to streamline a screening and assessment system across the state will apply to all youth, as well as a mobile crisis response and stabilization system. Those are not predicated on a youth being eligible for Medicaid, right? We're building things that will work for our broader population, but as a state-funded program, the benefits that we're designing are specific to the Medicaid population. So that's one important question. The next is, how does the settlement really relate to the transformation work we've been talking about over the past months more broadly? And I think to Stacie's point, as this was released, it's really confirming this path that we've embarked on over a year ago at Medicaid here. And so the way we view this transformation as it relates to the settlement, that the transformation is a bit broader. It's about overall behavioral health system reform across the state of Nevada for our youth here. The settlement has really specific guidelines, right? Bars that we're required to meet regarding those benefits and the delivery system. And they're a little bit more specific about which youth are directly applicable to. We'll talk about, from the purpose of the transformation, how should we think about defining that population? And that'll be a conversation with this working group because that's actually not fully decided yet. So I want to call out that important point, right? The settlement is not the world. It's a very important piece of it that's underpinning our transformation, but the work we're doing is a bit broader. So that's very specific. I wanted to call that out right after the focus population, because you may think, oh, that's a pretty narrow group of youth in this state. And the way we're viewing this from a Medicaid perspective is a bit broader, which is important. So the next question I want to answer is, who's involved with achieving compliance, right? How is Medicaid solely responsible for achieving all 175, I believe, items in that settlement agreement? The answer is absolutely not. Well, we are the lead agency. There are so many people that are involved in this process. And I'm sure there are many that I'm missing from this slide, but I think it's a helpful way for you all to see how we're organizing some of this work across the Department of Health and Human Services from a leadership level all the way down to the daily work. So we have started what we're calling an interagency council, and it's made up of administrators across each of the divisions that you're seeing represented on this slide. We've already met to review some of these settlement agreement terms, and we're doing really specific meetings every other month on particular areas or topics that span a couple of our different divisions. So one example that I'll give you is on mobile crisis. We're having a lot of conversations with our sister agency support team. So one row below that, so folks at the Department of Public and Behavioral Health, the Department of Child and Family Services, and Medicaid, as along with many others, to discuss how do we really think about the mobile crisis requirements in the settlement and achieving those within our state systems. And so that conversation at the program lead level is being presented to our administrators at an interagency council meeting coming up. What's super crucial, of course, is not just staff that work for these agencies, right? Stakeholder input is foundational. You'll see the working group is listed here along with many other boards and consortia that have been ongoing in some cases for decades to really inform how best we design this work to make it work for our youth and families across the state. And at the bottom here is that core team of people that's really driving this work on a daily basis. I feel really lucky and humbled to work with people with deep expertise in Nevada system, in national best practices and behavioral health policy. And they are spending every waking minute of their working days devoted to this work. And so I'm excited to have more of them present some of that in these working groups coming up. So that's a quick snapshot of who is involved. I also wanted to give you a snapshot on what is the timeline that we're moving forward with. So you'll see there's a lot going on in this slide, and I won't go into every detail, but this is kind of the high level requirements that the settlement agreement includes regarding how we communicate what we're doing, right? How do we publish how we are planning to achieve compliance? That's called our implementation plan. How is that independent reviewer publishing what they're seeing and the results? That will become in the form of compliance reports. How are we using data in a way that really works for us to identify where the problems are and where we're starting to make an impact? That will be within a data reporting work stream. And a really crucial piece of this is, of course, quality assurance. How are we ensuring that the promises that we're making and the steps we're taking are leading to the outcomes we want to see, which is better access to high quality care for youth at home and in their communities. So that is a very high level snapshot, and I'm seeing the comments here. Yes, we will share the link to this presentation along with all others on our website. I know this is a lot of information and I want to make sure you all have a chance to really digest it, but we did want to share this is how we're seeing that timeline. All these dates are reflective of what's in that settlement agreement document. So another important piece of this on the benefit side is we've seen this visual, right? You've seen this, I think, at each working group meeting so far. This is how we really are seeing the behavioral healthcare continuum. And I want to recognize the early identification at an early age is something that we received good feedback on, as well as school health services. So we're working internally to incorporate that more clearly in this visual moving forward. But I did want to call out, where does the settlement align with this continuum? And the good news is there's a section for every piece of this, right? So if you want to take a look, you can kind of map back to this, but each piece of the continuum is something that's addressed by the settlement. It's not just residential treatment. It's not just outpatient treatment. It's the whole continuum of care needs to be improved and really looked at through this particular lens. So I think it's an important piece on the benefit side. Everything we've been talking about is addressed, and we have a very clear standard that is set by the settlement agreement that we are already working to meet through the efforts that are underway, and we will spend the coming years doing so. So that's on the benefit side. One more kind of explainer on the term related to our delivery system side. So I think what's important here, we've talked about the managed care plan, and I know there's been a lot of feedback on that approach in this meeting. So I wanted to share a little bit more about what that looks like in our settlement agreement here. So you'll see on the right, similar to before, the blue box is the definition that's included in the settlement agreement. What that means on the left is that the state is required to utilize a new delivery system to deliver these benefits to eligible youth. So we can't just build all the benefits that we're required to and have those delivered within an existing fee-for-service or statewide managed care contract. We are held to a standard that requires something new to better support and serve these youth. And so our specialty managed care plan must meet some of the basic requirements outlined in the settlement, including sufficient provider network, full Medicaid benefit set, as well as these really targeted behavioral health benefits that are described in the agreement. And importantly, this delivery system will be held to standards that are beyond standard Medicaid managed care. This is intended to be a very unique model. And as such, we have a chance to design it in a way that really does uniquely serve this population. And so, as we've shared before, stakeholder input is absolutely crucial to this design. No decisions have been made at this point, right? We're going to have a number of opportunities for the public to provide input, feedback on how we're initially thinking about designing this to ensure that this system of care really serves our youth and our community in a meaningful way. So I will pause there. That's a lot of information. We have another discussion that we're going to head into related to what's our path to compliance? What do the next 5 years look like? And by section, what does that really look like? But before we go there, I'd like to pause. Do any representatives have questions they'd like to add to the chat here? Or members of the public, we're happy to address those. We do have a public comment period and discussion period at the end, but I want to make sure for anything up till now, are there any questions that folks would like to add to the chat? Yes, James?
Yes, thank you. So I've noticed in some publications that for the specialty managed care plan, it states that there are around 67,000 children with STD and then around 4,000 to 5,000 foster care members on average annually. But it states that there will be only around 10,000 to 15,000 eligible members for the program. Is that based on level of severity and being eligible for residential treatment?
Yeah, so James, I'll answer this one. Some of those early numbers were incorrect, I'll be honest. So once we looked at the full population, the at-risk population, and we think it's a lot larger. I don't think it'll be up to 67,000, but I definitely don't think it's going to be 10 to 15. So as we start to really, the next step now that we have this agreement signed is to actually go in our database and start identifying the kids and get that baseline data with our independent evaluator. And then we'll come back to this group to show you like how many kids we think we currently have, what we consider the focus population for the DOJ. And Anne, I don't know if you want to go to the next slide with the bubble. Is it a bubble next? Okay, I like this slide. So that dark bubble, James, right there is like is what we will first determine. But like I mentioned, we're looking at more kids being able to get into the plan and to get into this delivery system for services that might be in the private market through Katie Beckett, but then also at risk. And we want to also get upstream. We don't want to just wait till they are in the system in terms of like they had a visit at the, mobile crisis or they ended up in an institution, right? We really want to get kids where we get them earlier. So we're actually going to be trying to pull in way more or allow families that want to opt in to get some of these services early. I hope that answers your question, James. Sorry, it was long-winded.
Oh, no worries. Thank you. Yes. So at a future date, you'll have more refined eligibility numbers. Okay. Thank you.
And to an earlier point, James, it's an important one. I'm glad you asked. We will also be sharing kind of what those that definition of at risk looks like in our initial definition and get feedback on that from this group, right? There's a lot of different ways to look at this. So we want to make sure we're being as inclusive and broad as possible within the bounds of our federal and state regulation. So there will be more conversation in this forum about that very definition coming up as well. And yes, Leah?
I love that you guys are looking at the Katie Beckett option, but I'm wondering, are you guys including those children that are in like juvenile detention who are under the FIA service who now no longer can apply for Katie Beckett? So in our current situation, which this might be sharing too much, but my daughter, she was in juvenile detention and under FIA service. And so at that time, we weren't allowed to apply for Katie Beckett. Yeah. And then once we had that application in, when she came home, she did have to go back and that voided that application. And that's a very extensive application. It was over 100 pages for us. Plus we were required to provide 3 years of medical history. And with her history of going in and out of facilities, that was a really extensive application for us. So if we could, or at least I'm just trying to bring awareness of some of the problems that people might face with private agencies applying for Katie Beckett. Maybe we can work on simplifying that once we get to that section.
Yeah, I
Does
mean,
that make
Leah,
sense?
yeah, it does. This is Stacie. There are certain requirements we can't get around at the federal level, but we definitely can, like we always talk about why is that, why, often in our work it's bureaucracy and it's there usually for a reason, but sometimes we go back and we're like, why is that there, right? So I do think we should look at that. And that was the purpose of this group really, is to help us identify those types of challenges for families and how do we remove them? Or how do we balance that with whatever it is we need to do, right, to meet a federal requirement? So on the point about the detention center, so there is an element, so there's 2 other projects that I think I wanted to bring up that really are in it should be really integrated into this work as we move forward. One is our school health services work, right? For this population, but also our work on implementing coverage. It's new coverage under federal law as of January 1, 2025, kiddos that are in juvenile justice system, 30 days pre-release, we are required by federal law now to cover case management, EPSDT, which is all the screening, assessment, treatment, diagnoses, all those things. So it's exciting, but we got to get all the facilities enrolled, right? They're all the things. So we're working on that right now. We have a whole team doing that. And Anne, it might be great at one of these meetings to have that team bring that work and update here, because those are the same, these are the kids that are eligible for these services when they're coming out, but we also want to make sure now that we have coverage 30 days pre-release, that we can provide that coverage. Hopefully this time next year, we'll also have 90 days pre-release, because we're asking that in a waiver to extend that to 90 days. We just submitted that waiver too right before the holidays. So that work is underway as well, which I really think will help. These kiddos are in that focus population. So we definitely want to make sure that they're in this bucket. But that's a great question, Leah, because that back then there really wasn't an option at all when the child was in detention.
That is absolutely fantastic. And I'm so grateful to be a part of this group where I can provide input for that. Thank you so much.
Thank you,
And
Leah.
before you move on, Anne, I just wanted to note that Dana had a great recommendation that we should probably get NDE, and I totally agree. We have a school health services team. Melinda is on this call, who runs that team, and she's been working with NDE on getting all of our schools enrolled, because we removed the county barrier. Before the county had to pay the state share, and we realized, A, that's not statewide, that's a federal requirement for Medicaid, and two, a lot of counties can't afford it, right? And that's a barrier. So we have picked up the cost for that. And so all counties can start billing, all school districts can start billing, and we'll pay the state share like we do for any benefit that's a state plan benefit. So we're hopeful more schools will take that up, and we're hoping over time that allows schools to get more behavioral health services and screening in. But that's a big area where we really need to do some coordination. So I think, Anne, we might want to have a meeting with NDE and figure out how we can loop some of them into these work group meetings. So thank you, Dana.
Yeah.
Go ahead.
Oh yeah, I'm excited. I mean, it's exciting, and it is happening at school. So thanks for including us. And
yeah. Thank you, Dana. Relative to the detention kids, so I just was reading this. Matthew put a note in. Relative to detention kids, does that include pre-detention kids, such as those in diversionary court programs? So there's a legal definition here. Apparently, if a child is considered in custody, which I think would include diversionary court programs. I'm looking at Gwyneth, our attorney, our legal person. I think,
Hi, everybody. This is Gwyneth. I'm with the DA's office in Clark County. It's a good question. I think the answer is that if the child is not in custody as a physical term, is the child residing in a detention center? So if they have, for example, a juvenile justice court case in day court, but they're living in the community, my assumption would be that they would qualify for all of this as a child as part of the focus population in the community. Right? So yes, I think they would meet the definition of the focus population.
Great. Thank you. Thank you, Gwyneth. Karen, I see your hand is up to you.
Thank you. I think this is great that we are standing up programs. And what has happened in the past is programs are based on eligibility, right? And so when a youth is no longer eligible, then the supports and services often go away. And I think that this group should be thinking about that. What do we do if we've done all this great work and a youth is no longer needing residential care? Are we dropping the services? Are we dropping the programs? Because historically, how we've done things is based on eligibility, not really based on the needs of the youth and the families.
Yeah, Karen, I think that's an important point. I will just note that this does cover up kids up to 21. I think there are a couple things that I would just say that the goal, I think what we heard strongly from the DOJ folks too, is that by getting to kids early, they're more likely to be able to be more successful when they become adults is when, you know, the system we have right now, they're going to continue to cycle in and out of inpatient residential treatment. You know, we do cover in Medicaid, all the therapy, all those types of services, but access continues to be a challenge for our adult population, which I think is something we're going to have to talk about and tackle beyond just Medicaid as our workforce, right? And then the other point I wanted to make, and because I want to think through this a little bit with everyone, is how do we do this in a way where, you know, families and so kids don't have to stay at home with their parents either, right? Like they feel like, you know, one of the things we have to, I don't know, Anne, if you included it, is we have to cover employment supports and independent living and all those types of things. So while we're building this out, that's something I'm hopeful that can help youth as they're coming out of their families' homes, get stable jobs. But you're absolutely right. And Karen, all that's going to cost more money. And so we have to figure out how we're going to pay for all of that.
Dr. Pebbles, I'm excited that you're here.
Yay.
Maybe before you give your input, I will actually just turn to your quick intro slide. I think it's well timed, and then we'll come back to the discussion. So I will turn it over to Dr. Pebbles to introduce herself, but she is our new clinical advisor for our Children's Behavioral Health Transformation team. She's actually joining us after just seeing some patients in the moments before this call. So really want to thank her for taking the time out of her clinical schedule to join us. And I'll turn it over to you to share a little bit more.
Thank you. So good evening, everyone. Thanks for logging in for the meeting. We greatly appreciate it. I'm Dr. Christine Pebbles. I'm a psychiatric nurse practitioner. The doctor comes from 8 years of school and a clinical doctorate as a doctor of nursing practice degree. I've been a psych nurse practitioner for about 5 years. I did just come from seeing kids in the foster care system in Vegas. I do have to return to it shortly after this meeting. I have a couple more appointments to go to, but I do see kids in the foster care system in Vegas. I've been the nurse practitioner at Jen Evans Juvenile Detention Center, in the rural clinics, in a private practice, in an acute setting, whether it's the ER or on a medical floor or in a psychiatric ER. I've seen them in many different areas. I have 4 children of my own. They all have their own mental health needs. I ended up treating the pediatric population because my daughter was diagnosed with bipolar disorder at 14 after having been hospitalized 3 times. I decided to be part of this group because I recognized then that we had the means and the access to get care, but we were one of the very few. And that's the only reason why she is doing as well as she is currently, and she's completely stable and everything's been well. But I understood that, you know, it is a struggle to say the least. And so I decided to be part of the solution as best as I could with this work group. So we definitely do appreciate you all logging in. We're doing our best to get everything from each angle, but we definitely greatly, without lack of a better term for it, appreciate all the time that you have taken to help us with this massive endeavor.
Wonderful. Thank you, Dr. Pebbles. We're really thrilled you're here. And I'm excited for many of you. You've seen her name in your inbox because she's reached out to our providers in the work group first for one-on-one conversations about a number of these topics, but she'll be diving into our screening assessment and managed care delivery system design first, as well as providing clinical advisement on all of our development of Medicaid benefits, and all in her short part-time with us. So I'm really appreciative of her energy and numerous really thoughtful perspectives that she's bringing to this work. So looking forward to many more conversations with her to come. And if you'd like to reach out to her directly, I've included her email there as well. And Gwyneth.
Yes, I just wanted to pick up Karen's question again, just to make sure I understood, and it may be me not understanding. But in terms of the eligibility criteria, which rest on the child's level of acuity, right? The hope is we put in these enhanced services, the acuity decreases, we stabilize the child. What is the timeline for them remaining eligible, right, for the enhanced services? And when would they drop off into whatever the default is?
21 is age 21.
So literally,
And
so if the
27, 27 for foster care, right? So eligibility under the foster care bucket is longer. So they would have a longer trajectory.
So if you meet the focus population definition, whatever, let's say at 15, once you're qualified, you can qualify for these enhanced services until you age out, essentially.
Yeah. Yes.
Okay, Great.
Yeah.
That's
But it is
wonderful.
something to think about, like what services do we need to, that we may not have for our adults? I mean, I feel like we do often have a lot of those services just access for adults, but like what else are we missing is something we should think about for that, like that cliff that could happen, like I think Karen is pointing out.
Absolutely. Yeah, thank you all for raising. I think we'll have many discussions in this working group related to what's the front door to these services and these new benefits, ensuring it's a no wrong door approach and very clear and accessible in moments of crisis and challenge. But also equally important is for lack of a better term, what's the back door, right? What's the transition back to other services in the community, and ensuring that's seamless and does not leave people without the care that they need in a way that aligns with this work. And to Karen, your point, and Gwyneth, your point, I really appreciate that. And I'm looking forward to discussing with you both and getting into those details as we design this. Absolutely. So with that, I'm going to move forward into our path to compliance. And I again encourage folks to drop questions into the chat as we go. So this is a very high level summary of how we are thinking about these next 5 years. Recognizing we're all aiming to get green sooner than December 2029, but that it may take us the full 5 years to really develop a system that not only is established, but it is working well for our youth and families, particularly as it relates to provider access. That we know that takes a lot of time. And so trying to set a challenging but reasonable target here. So you'll see year after year what progress we think will be made. This is again at that high level and aligns with the timelines that you have been seeing. We're really spending the next year finalizing all of our new benefits that we're developing from the Medicaid perspective and starting to establish the systems to track our data and our performance data. To Stacie's point, begin our work with this independent reviewer and have their expertise and eye on this work. We will be spending this year really starting to design what that specialty managed care plan looks like, again, in preparation for the procurement process for a December 1st, 2027 launch date for that delivery system. So I think what's perhaps a little bit more important than even this high level summary is what this looks like by section. So our team has done some preliminary work to start mapping out our compliance with every single item in that settlement agreement, what steps we're taking, who we're working with across the state, county, local agencies to do that, and what that timeline looks like. So we will be spending each of these working group meetings diving into different sections over the course of the coming year. I'll preview that section 5 is what we'll spend some time with next month, but I wanted to give an overview of these sections so you all get a chance to kind of see how we're thinking about parsing this out, and may kind of inform as you all, if and when you guys take the chance to read the full document, this may orient you to how we're thinking about it as well. So on section 3, again, this is our screening and assessment focus. And the goal set forth by the settlement agreement is to develop a statewide system of assessment to ensure that all Medicaid eligible youth receive timely screening and referral into the comprehensive assessment process where it's clinically indicated. There are so many agency partners that will be involved in this. And Dana, to your earlier point, we do have NDE on this one. And so it'll be really crucial to partner with our education system as we think about meeting our youth and students where they are. And so we are going to begin this work with Dr. Pebbles and many others at the helm to start having conversations with you all. We know every single provider and agency is using a slightly different flavor of screening and assessment tools. And we want to find a way to really progress towards our settlement requirements in a way that is not increasing administrative burden and allows a really comprehensive single assessment for youth across the state. I think other states have described it as a one child, one assessment, which I think is really crucial. And so we're really thinking about what are best practices we can bring to start to develop that work here in Nevada. So I know this has been ongoing for many years as well, and so we'll be build off of all of the lessons learned, and I appreciate many of you all who we've already discussed what some of those lessons are. We will be discussing this in more depth with the working group, likely late spring, so expect more to come, and Dr. Pebbles will be a great contact for those that would like to have a dedicated conversation about this beforehand as well. So section 4 here is on our service planning and coordination. What that really means is developing a tiered system of care coordination to receive that all youth in the focus population receive direct support via either intensive care coordination or wraparound facilitation. And that depends on the clinical acuity and level of need here. There's a lot of work being done already in Nevada to do this, and I think ensuring that it really reflects the standards that are set in the settlement and finding ways to really build the provider base for this will be crucial. So we are working with our national expert vendor partner on this, as well as our independent reviewer once they're on board, to really think about what are we doing now in Nevada and how can we really streamline this to best serve our youth. This is, to the earlier point, a little bit more about that front door to services that I think is really crucial. So a lot more conversation to happen about this one later this year as well. Section 5, as I mentioned, is on home and community services. So this is the meaty section all about what benefits are we designing to build our outpatient and home-based behavioral health system of care here within the Medicaid system. We will be spending a lot more time on this section in our upcoming working group. We really want to share with you how we are thinking about tackling this and get your input on how and where we should spend extra time and effort in the very short term. So I'm looking forward to that conversation in February, and this will be an ongoing one. We will revisit this likely every month as well. So diversion and transition is the name of section 6, and I know we're moving quickly here, so I appreciate your patience. Again, questions welcome in the chat, and I appreciate that. For my team, stop me if there's any question that we should handle live. For diversion and transition, this is really about how are we ensuring youth who enter residential treatment facilities do so at the right time when it's clinically indicated, and they have the support around them to really thrive and return back to their community or to a lower acuity of care as soon as they're clinically able to do so. This is one we've actually done a lot of work on already. I'm excited to share more later in this presentation about some of the changes to our psychiatric residential treatment facility policy, as well as reimbursement structure. I know we previewed that at our last meeting as well. There was a great policy workshop covering those changes. So maybe someone on our policy team can drop a link to that from our website in the chat here if you're interested in reviewing, but we will spend a lot more time covering those updates at that February meeting. We really are looking for this working group's input on the quality incentive payment in particular that we're designing. How do we create a structure that rewards PRTFs for really delivering that high quality care to our youth in accordance with the settlement agreement terms? So I'm looking forward to that discussion coming up as well. For section 7, this is our stakeholder engagement. It is green, not because it's done, but because it will be part of every single year and it's already ongoing. So this working group is one aspect of this. We will also have a number of meetings additionally related to our specialty plan design, like I mentioned, along with other meetings with stakeholders to inform just other aspects of the system, right? I imagine Dr. Pebbles will likely have a very dedicated conversation about screening and assessment as we get farther in that process. And so we are really eager to find ways not just to share the information, but to hear from you all at every step of the process. So if there's things that we are doing that you have feedback on, or you have ideas of how we can best engage with other aspects of the community. I know this meeting is one important way, but it's not the only one. So we have a running list of other strategies that we're planning to roll out, and we look forward to your input on that as well. 2 more sections here quickly on our workforce and provider development. This is crucial, as we all know, to building a system that works for our youth. It does not matter if Medicaid has created the benefit if there are no providers to deliver it. And so this is one where we're really working in lockstep with not only our sister agencies, but folks across the state that are really spending a lot of time thinking about our workforce from the earliest process, from the earliest phase of education and training, all the way through ongoing training to ensure that our existing providers are really well positioned to serve our youth, particularly youth in this population. So a lot more conversation to come on this. And I will say Medicaid is not the only solution here, but we're really eager to think about what levers we can pull on our end to help support this workforce and provider development. So more to come on that one soon as well. And the last section that we'll cover here is related to quality assurance and performance improvement. So This again is crucial for us to really start to measure what we're doing, both in data and qualitative feedback through independent review and many other sources that will be published publicly. So I'm looking forward to our first conversation on this with our baseline data report that will be published in July 2025. And we will have, I know, many other conversations to come as well. So I will pause there. Actually, I have one more slide and then we'll turn to discussion. So I appreciate your patience, as I know this is a lot of information today. I want to call out what I shared earlier. Our next working group meeting is really going to be focused on our home and community-based services. So section 5, we will be presenting kind of the sequencing and how we will be going about developing these benefits at a higher level, as well as a few areas where we're looking for more immediate feedback. So looking forward to that discussion coming up next month. So I will turn now to our representative discussion. Welcome any thoughts, feedback, or questions on this overview. I know this is a lot of information and we welcome your questions over email after as well. I've been seeing a lot of conversation in the chat related to CANS and assessment, which is wonderful. I'm really looking forward to digging into that one with this group as well. Any other questions here?
And I just wanted to say real quick on the assessment piece and the screening. So under the agreement, we have to screen all children that come into the system and to the state access points. So I think we're going to be looking at using our MCOs to require all primary care clinics to offer screening to parents. Obviously, things can't be forced. There's always parents that, that have to be involved in this process. But like I know Dana put in about schools and how we will do screening with that. But once a child is screened, and then if they are indicated they might have a behavioral health need, then there's the assessment, right? And that's the CANS, and that's more of the level of need. And then that assessment helps identify treatment from there. So I just wanted to clarify what we mean by universal screening, but also universal assessment too, that we need to put into place, which is kind of a bigger lift. So I'll stop talking and we'll open it up.
So if I could talk for a quick second, I was answering stuff in the chat and I'm sorry, I've been typing all day and my fingers are going faster sometimes than my brain is going. So with the screening itself, there is screening that needs to be done, mostly focusing on the group that is at the highest risk. Of course, there'll be periodic screening of other children and adolescents that will be done. Right now, we don't necessarily have the parameters for that, but we're working on it. So again, we value your feedback as far as that's concerned as to what you think would be appropriate, right? And what is reasonable. Screening every single child in the system is the optimal plan, but it might not be something that's realistic at this point, but that's something that we're looking at. I see it all the time. Like I said, I see kids all day, all the time, and I see these different things and I get to hear different perspectives of, how long have you had this going on? What could have been done differently in that whole process, right? Because a lot of kids kind of fall through the cracks and they've been dealing with depression or other diagnoses for quite some time. For instance, I just met with a child who meets a lot of the criteria for the onset of schizophrenia. She's been dealing with it for a year. So we have to look at things of, how did that get missed? Did she just not report it to anyone, which is quite often the case with adolescents. They don't really want to reach out and tell anybody. So thinking about, how do we screen kids effectively to where we're not overwhelming all of the systems and all of the stakeholders that have partnered with us, but that we're also making sure that all of the kids are getting attention that they need. And I think part of that is the school process, because teachers do spend such a large amount of time with the kids. That's something that we really need to look at. But again, we kind of defer to you of what your ideas are, because we can say what we think might work. I might say what I think can work, and I'm a practitioner, right? I'm not a teacher. I'm not someone else that's in a different kind of position. So really, this is where we value your input of what you think would work as far as assessment and what's doable. And I know I was answering some questions in the chat as far as reimbursement is concerned. And of course, that's something that we are going to be looking in, because any kind of worthwhile screening is going to take time. And I'm a practitioner and I work on what's my billable time. So we do have to take that into consideration, something that will not be overwhelming to complete, something that will not take, a degree in physics to fill out, but that will be worthwhile for whatever practitioner that particular child is handed off to, that practitioner now has a really good grasp of what's going on with that child, not only to see, do they have the expertise to deal with it? Are they aware of what the acuity level is, and is that appropriate for outpatient care? Where could that child be sent? Is that something more acute in nature, or is outpatient appropriate. So we're developing that, and we're working with the CANs as well as other assessment tools to see what would be the best screening for Nevada. Because we can have lots of screening for everybody else, and everybody else has used this one and this one and this one, but we're Nevada. We have rural areas, we have frontier areas. Our situation is unique, and so we want to make sure that we play to that uniqueness as well.
Thank you, Dr. Pebbles. Yes, Jake?
Thanks. Just to clarify, I don't want to be like all Johnny Raincloud without solutions here. I'm just aware that we're doing a lot of signs of suicide screening already, and that uses, something like the BSAT or whatnot, and which I think is the funniest acronym on the planet, by the way, for a depression screener. But we got to be mindful of what we're asking of the people on the ground floor who are administering these at whatever level it is. If it's the people who are in the system, we got to define the system too, I think, and maybe that's defined in the document. I didn't read it that
It's in the
closely.
agreement. It's in the agreement. Yeah.
So is it all children living in Nevada, or is it all Medicaid members, or how does
It's
it work?
Medicaid. I mean, really, our legal liability, under the ADA is state funded services. But like I said, we're trying to make sure that families that need access to these services can. But there is a universal screening where any access point, like schools we've talked about. So I think we need to work with our independent evaluator who will determine whether or not we've met the requirements. And so I kind of want to, if we can, table some of that and bring that back to this group once we get options from them, because they've worked with other states on implementing this agreement. And so I think we'll have more for you guys. Like, here are the options, here are the venues, and here are the, where are the pressure points? I totally hear you. One thing we've been thinking about is incentives instead of sticks, right? There's carrots and sticks in our world in Medicaid. It's either we give you a carrot and we hope you help us get it done, or we give you a stick and we take you out, or we don't give you the money. So what we're thinking about to get providers to do the same screenings and to do the right assessments, at least on the Medicaid side, is incentive payments initially to get everyone on board, because we know it's going to be a lift.
Yeah, I didn't want to get too weedy here, because I know that's down the road. But my big concern is that we end up with over pathologizing normal life. So not everybody maybe needs to get into the system. So it's just something to be mindful of, that we don't just overwhelm either with legitimate concerns or even the false positives, like I mentioned. So
Totally
that's all.
agree. Thanks, Jake. Glad you came to the meeting. Thank you. Jessica, I am not going to pretend to pronounce your name. I wish you're going to have to pronounce it again for me. It's amazing.
Gogachia. Hi.
Gogachia. Hi.
I think that just from a clarity standpoint, talking about mobile crisis, are we talking about just like the specific as defined by Medicaid mobile crisis units, or anybody who does mobile crisis response when we're looking at this? And if it is kind of anybody who is doing a mobile crisis response, it might be worth, like, here in Washoe County, we have a crisis collaborative. And next week, for example, we are meeting with everybody who is doing any type of, that we are aware of, that's doing a mobile crisis response. And we are putting together, like, what does your mobile crisis response team do? What are your hours? How do you respond? Do you go in person? Are you a team response? So it's, it's MOST, it's Quest, it's our Washoe County response. It's, it's our team response. It's our, our REMSA is coming to that meeting. Like, we're going to be doing it all. And so as you guys are having your discussions, those might be other teams that are doing these responses that may be important to that discussion. If all of those teams are needing to be doing the same stuff, because as I was reading this when we first got it, right, and we see, because we are, we are the Washoe County Mobile Response Team as identified. And so as I started reading this, going, okay, so we are one of these, like, it doesn't matter if you are fitting under this, Medicaid eligible children, where we are required to do this data on everybody. But are these other entities also required? And then should we all be at the table to sort of identify how we're going to meet this bigger, this bigger picture?
Yeah, no, I mean, I think just remember that we have a lot of time. So we have time and we are going to have a whole meeting on, there's other people working on mobile crisis. So my understanding, if I'm remembering correctly, mobile crisis was a little bit broader and the settlement agreement than some of the other services. So I think it is a broader approach. But I think we'd like to have a more focused call on that and really dive in. Where are the barriers? The good news is we get to face this, right, over time. We don't expect everything to providers to be able to comply right away either. We know it's going to take time. So, but it's a really good point. I'm glad you raised it for the team.
Yeah, thank you, Jessica. And I just dropped in the definition in the settlement agreement if it's helpful to your immediate question, but the broader point about how are we ensuring everyone's at the table, there are, to Stacie's point, many conversations to come about this, and I'm really looking forward to working with you directly, as well as all of the partners that you mentioned, to ensure that we're reflecting all the different variations of mobile crisis that we have in our state to support through this process. So thank you for raising that. I recognize that we are moving up on time, so I'm going to keep us moving. Please continue to add questions in the chat. I want to call out, we do have a few updates from follow-ups from our December working group. Our team has spent some time reviewing and assembling your feedback, and I'm going to move through these very quickly and identifying what action steps we've taken for each category. So instead of spending time on that today, because we don't have it, we will be sharing a memo with you all after this meeting in our kind of follow-up documents to really share a little bit more about how we are tying this feedback that you're providing in this meeting with some of the items that we're doing or new things that you've raised that we've then acted on in the past month. So look forward to more updates on that front. But before we move forward, I just want to call out our next meeting is on Thursday, February 13th from 4:30 to 5:30 p.m. So I'm looking forward to that conversation. And with that, I will open it up for our final public comment period. And Karen, I'm seeing your hand, so I will turn over to you and then open it up for public comment. Thank you for raising.
Thank you. There is so much information. I am just wondering, either we can get some of that ahead of the meeting or the meeting's a little bit longer than an hour, because I think we have such great people assembled and there's just really not enough time to hear their perspectives.
I appreciate that. And I think you're right. We're all feeling the same time crunch here, and I'm wishing we could spend more time. So let us take that back and think about how we can share more in advance and make this even more discussion based in the meeting, as opposed to talking at you all. And I'll also think about the timing here, recognizing we're trying not to burden folks' already busy schedules, but also really want to make good use of this time as well. So thank you for raising that. And we will take that back and see what changes we can make as early as that February meeting. Dr. Cooper?
Thank you. So this is so very exciting and very ambitious, but I agree this is just what we need to do. When I'm thinking about Nevada and behavioral health for youth, it seems like I'm hearing that there's just not enough providers, not only providers that are well trained, right, in evidence-based treatment, but just there's not enough people. And so I'm worried about how will we really expand the workforce within the time frame, and to make sure said workforce is well trained in evidence-based practices, cognitive behavioral therapy, dialectical behavioral therapy, et cetera, which we know are effective. So I saw the Center of Excellence, which I think is a wonderful idea, but I think we really need to think about how are we going to get more numbers of behavioral health clinicians in the area to do the work.
Absolutely. That is a deep anxiety I feel, and many others I know on this call as well. So thank you for raising that, Dr. Cooper. You'll see in the settlement agreement, we're required to develop and document a workforce plan as it relates to each one of these benefits in the system overall. And so I look forward to more conversations with this group on that topic, right? That plan will be informed by input from you all, ideas and other things that are ongoing. I know you have a lot of work in the UNR realm that can probably tie into that we'd want to have reflected. But there's many other things that we need to do in addition to what's existing. So calling that out, it is a concern and it is an area of focus that the Department of Justice recognized as well in this agreement. And so a lot more conversation on that topic to come as well. Thank you both. So with that, I know we are at time. I will be staying on for our public comment period, but want to thank you all for joining. So as always, this is now an opportunity for folks to offer public comment. No action may be taken upon a matter raised under this period unless the matter has already been included on our agenda, and comments will be limited to 3 minutes per person. So if you'd like to contribute public comment, you can raise your hand now or press *5 on your phone to be speaking. Yeah, James.
Yes, thank you. So Magellan Healthcare currently holds the care management entity contract for what seems to be the majority of this population. With the new Medicaid managed care program, the specialty managed care program, will that replace the CME model, or will the CME model continue to exist as part of the new managed care plan?
James, I'll take that question. This is Stacie. I would just say that that is an ARPA funded project, and it's a pilot. And so we'll see how that project goes. Right now, that's still, I think it's something we have to think about. CMEs are, care management, that is part of the managed care structure. So either we have an entity to do that, or we ensure that the managed care plan can do that. So it doesn't mean that they can't exist together. It's just that right now that project is a pilot and it's not ongoing funding. So we have to see kind of how we move that forward.
Thank you.
All right. Well, with that, thank you all for your time. I really appreciate you attending and taking time out of your evening. I'm looking forward to our discussion next month, and likely we'll be sharing some materials ahead of time. Thanks, Karen, for that recommendation, but a lot more work ahead of us, and I'm really excited to do it with all of you and humbled that you've all taken the time to really work with us together. So thank you again for that time, and this meeting is now adjourned.